Hi, this is Brian Kim. I'm going to share with you case number 17 and the best way to do cataract surgery series. This is a medium-sized pupil, 1 to 2 plus dense lens, but the biggest part of this case that's the most problematic, it's the sticky and annoying lens. This lens doesn't want to spin when you hydrodissect it. This lens also, after you chop, the pieces don't want to come out. They're all kind of stuck together. And again, this is not a leathery posterior plate. This is like the sticky, adherent, all the pieces are kind of all stuck together like they're stuck with molasses or something. Very annoying, very frustrating. If you don't handle these cases well, you'll get frustrated. You'll end up bowling out the lens. You have this sticky lens that doesn't want to come out of the bag, and you have this bowl, and you try to grab it, and every time you grab it, it just kind of pulls up and then falls back in. And the pieces just kind of break apart, and it's very, very frustrating. So this, in my opinion, is one of those cases, and you will see how I'm able to take this lens out without too much fuss, without too much frustration, doing the mechanical fracturing techniques and using mechanical forces to pull the lens pieces out of the bag. So I'm going to use my corneal mark to help me center and size my capsular rhexis. I make my superior and inferior paracenteses incisions. I'm injecting intracameral lidocaine with epinephrine to see if I can dilate this smallish pupil. I'm injecting dispersive viscoelastic and then using the cannula to hold the eye still. I do my triplanar corneal incision. I make a vertical groove and then tunnel and then enter the anterior chamber. I start my puncture style capsular rhexis. This is a youngish 50-something-year-old patient and the puncture technique doesn't work. So then I use a cystotome to make a puncture and create a small C-shaped flap. I use my forceps then to grasp that flap and go around circumferentially, grasping and regrasping, making sure I follow the corneal marks that I made to help me center and size my rhexis and make sure I don't push on the wound and to minimize any viscoelastic egress during this maneuver. After I finish my rhexis, I burp viscoelastic to decompress the chamber, and then I go to my capsular fornix hydrodissection technique. I go in with the hydrodissection cannula, go across, underneath the anterior capsular surface, turn the tip down facing the nerve, and I get a nice fluid wave. As I try to spin this lens, I'm having quite a difficult time spinning the lens. Again, this is an early sign that this is an annoying and sticky lens. I'm trying to turn the lens. It's not really working. I'm turning and I'm turning. I try to do a little bit more hydrodissection. It's really not working. And then I'm really trying one more time to go out to the capsular fornix, and then I'm able to finally spin this lens. With a lot of effort, I was able to spin the lens finally. I lift my corneal incision with my chopper. I go into the eye with irrigation off to minimize Descemet's trauma. I place the chopper out to the equator, place the phaco-tip vertically in the subincisional space. I bring both instruments together, crushing the girth of the lens, and this is the double chop maneuver. I place the chopper out to the contralateral equator and pull the chopper centrally towards the phaco-tip, and I'm able to crush the right heminucleus. The first quadrant comes out very nicely, and I'm able to emulsify the lens using bursts of ultrasonic energy and vacuum. However, the second quadrant is not wanting to come out. It's a little bit sticky. I use the chopper to pull the lens out again. It seemed to work, but it took a little bit of effort. I turn the second heminucleus in front of me. I place the chopper out to the equator, and I crush this lens piece as well. But lo and behold, as I remove the third quadrant, I noticed that actually I only removed the surface portion of that third quadrant. It only kind of just broke off the top part. Again, this is that sticky and brittle type of lens, very annoying. So then I take the chopper out to the equator, and then I go deeper with the phaco-tip, and I'm able to crush and break the lens completely apart. And you can see that red reflex shining through very nicely as I do that. And again, with these sticky lenses, the epinucleus and endonucleus are all kind of stuck together. They don't want to separate. And because of that, you have more exposure to the posterior capsule. You can see I'm using successive mechanical fracturing forces, placing chopper out to the equator, crushing the lens pieces between the chopper and the phaco-tip. And you can see this sticky, gummy, very annoying pieces are able to come out very nicely, being patient and crushing the lens pieces. After I'm removing all the lens material, I place the BSS cannula to keep the chamber stable. I take the phaco-tip out and then I place my INA handpiece to minimize any fluctuation in IOP, and this is to maintain intraocular pressure stability. As I'm doing the INA, I'm removing the cortical material, and I'm going around sweeping into the capsular bag. I can see that there's a lot of cortical wisps. I'm removing the cortical wisps using the polymer tip, and I'm able to confidently remove the cortical wisps from the posterior capsular surface. And then I switch to the polish mode, going underneath the anterior capsular surface, as well as on the posterior capsular surface, to remove any potential lens epithelial cells. I'm going to go through the paracentesis with the BSS cannula, and I'm pulsing the subincisional space, the subincisional capsular fornix, and you can see there's some cortical material that's coming out. I'm continuing to pulse BSS into this space to remove and loosen up the cortical material. I then inject cohesive viscoelastic into the capsular bag. I use a capsule sweep to polish underneath the anterior capsular surface, first on the left side and then on the right side. I don't see much cortical material or any cortical wisps during this maneuver. I inject the one-piece acrylic intraocular lens into the capsular bag, and then I place my INA handpiece in without irrigation, and then I loosen each haptic separately. I rotate the lens 90 degrees clockwise. I tilt the lens to access the viscoelastic under the lens and enter the posterior capsule. By tilting it, I'm also pushing it a little bit into the capsular fornix, which assures that both haptics are in the capsular bag. I'm able to remove all the viscoelastic in the anterior chamber, and I'm making sure that there's no viscoelastic anywhere in the eye, and I'm bouncing the lens to make sure that the lens is centered and in the bag. I'm pushing BSS into the eye and take the INA handpiece out, and then I hydrate my incisions. So again, this is the sticky lens that doesn't want to spin, that doesn't want to chop, and when you grab the pieces, they're brittle and they kind of fall apart. I think this is one of the most challenging cases next to the leathery posterior plate cases, because if you try to grab the pieces with high vacuum, they just fall apart on you, and then you end up bowling out the lens, and the lens just doesn't want to come out the bag. In this case, using mechanical fracturing forces, pulling that chopper out to the equator, using mechanical fracturing forces to crush the lens, was able to make this case a very straightforward case. So I hope this was helpful to you, and thank you for your attention.